everyone, I'm Leslie Cornwell, Certified Nurse Midwife with Empowering Midwifery Education. This section has to do with prenatal care. A legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational use only, not intended to substitute for professional, legal, or clinical advice. We strive to keep our information as timely and accurate as possible, but make no promises and guarantees that it'll work for your unique situation. Course objectives, the students will be able to verbalize exactly what is prenatal care. They'll be able to verbalize the key standard elements that are included in prenatal care. They'll be able to verbalize the guidelines and the reference points for each stage during the pregnancy, standards, screenings, testings to be offering and to be talking about. This topic is important because prenatal care is an essential part of great birth outcomes. We want to reduce the risk of preterm labor, growth restrictions, depression, better breastfeeding rates, better birth outcomes. We really want to have screenings and education and touch base points throughout the pregnancy. There's so much data out there about late to seek care, no prenatal care, and the complications it has for not having those opportunities of touch base points with our patients and clients. We want to prevent unnecessary inductions. We want to get good further information. We want accurate assessments of due dates so we're not inaccurately taking care of preterm babies and postterm babies that really are after they're born. We can assess the placenta and the newborn to determine they were term. We just didn't have accurate due dates based on period or ultrasounds we were using. You want to be able to reduce the risk to the mom and the baby of infections and complications. You want to be able to talk about the evidence and standards and alternative therapies and what they're doing in the US, what they're doing around the world, and how often you see somebody, what do you check during that visit, what do you talk to them about, what are common concerns, what are warning signs. There's so many things that are included part of prenatal care, and there's a standard reference point. Yes, you can do things a little bit different way. You can talk about things at slightly different timings, but there is a core theme to what should be included with prenatal care. So let's go to the basics. What exactly is prenatal care? It's one of the most common preventative care services offered in the United States. It's an opportunity for the midwife, the healthcare provider, to see the health conditions of the mothers and babies and make sure they're doing good emotionally, physically, and spiritually. We gather a substantial amount of information. We provide education, especially those first few visits and towards the end of the pregnancy. There is a lot you go over. If their first baby, they don't know what to watch for, they're nervous, they're anxious, they're not feeling well. It's a huge opportunity to do education and screenings and get a good foundation to a successful pregnancy. So there's standard elements included in prenatal care. You want to have routine physical exams. You can offer a pelvic exam at the first visit. If they've never had a pelvic exam, they're at very low risk of sexually transmitted infections. They're under 21 and you don't need to collect a pap smear. You may or may not include a pelvic exam with your first prenatal visit. It's standard every single visit to do their weight, their blood pressure. There may be situations where weight is declined or they have a history of anorexia, weight problems. You might consider not doing it, but it's also an important screening tool, and you'll talk about the pros and cons of doing a weight during pregnancy and a blood pressure. You'll be able to check the baby's heart rate. After they're about 10 to 12 weeks gestation, you'll be able to check the heart rate on the abdomen, and if it's less than that, you can always check it with an ultrasound. The Doppler is a great tool to use throughout the pregnancy, depending on the hertz and what caliber equipment and specialty you use. And then after 20 weeks, you can use a fetoscope to listen to the baby's heart rate. A lot of times you'll want to check the maternal pulse just to confirm that you are getting the baby's heart rate, especially if they're very similar and during labor. You'll want to be able to start measuring the tummy, the fundal height, the top of the uterus starting after 20 weeks, and then you'll use more of a measuring, not a tape measure in centimeters, but you'll use your hand to measure before 20 weeks. Where is the top of the uterus? Is it at the umbilicus? Is it at the symphysis pubis? How many finger breadths above, below? You're going to do different measuring points. And then after the last month of the pregnancy, you're going to start doing the Leopold's, the baby's position from the belly with your hands to confirm that the baby is head down, and if the baby is sideways or breech, you'll have a discussion with a physician about aversion and considerations to think about if the baby doesn't turn by the time labor kicks in. There's key guidelines to consider with routine prenatal care. The first visit, depending on when it happens, if it's at 8 weeks, it's 12 weeks, 16 weeks, late to seek care, and 24, 28 weeks, will determine what you go over that initial visit. These are the common things you would do at a traditional prenatal visit that usually occurs between 8 to 12 weeks gestation. So you're going to want to get their blood type, and you're going to want to know if they're Rh negative or positive, and then the antibody screening. And if they are antibody positive, you're going to run further studies to determine which type of antibody they have the isoimmunization with. It's important to do a CBC, a complete blood count. That'll be the hematocrit, the hemoglobin level, signs of anemia, and the overall oxygenated blood capacity that goes through her body. It's normal during pregnancy to get twice the blood flow. It's normal to get the hemoglobin hematocrit to slightly fall. The peak of that tends to be at 28-30 weeks. That's why a hemoglobin hematocrit is recommended to check at the beginning of the pregnancy and at 28 weeks gestation, or if she obviously has any signs of anemia, symptoms, history. And then a lot of practices will repeat it around 34 to 36 weeks, depending on their population, the setting that they serve. If they've had a history of anemia, that is a common one to be repeated more often than not throughout a pregnancy. And then some other things they check for part of the prenatal panel would be a rubella and varicella immunity, just seeing if the mom is at risk of exposure. If she has had a childhood exposure to the chickenpox, or if she's had the vaccination. Rubella, a lot of times will need booster shots as time goes on of the MMR. So many people may be equivocal or not immune anymore. And then you just recommend postpartum to go to the local health clinic where you can provide at your practice a booster shot if that's something they want to do. RPR is one for the syphilis, and usually it's negative, and if it comes back positive, you'll definitely want to get some treatment. You'll want to get some history. You want to decrease the exposure risk to the baby during the pregnancy and during delivery and postpartum. So definitely one that important to do part of the screenings. You'll do a lot of sexually transmitted infection screenings depending on the population you serve and what risk factors are in the area. Typically, gonorrhea and chlamydia are the more common ones that are tested through pregnancy, but you can definitely add much more based on the population you're serving. A urine analysis and a urine culture are recommended the first pregnancy visit because 25% of women have asymptomatic bacteria, meaning there is an infection present, but they've had it for so long they're not having signs and symptoms of it. It does increase the risk of preterm labor, kidney infections, complications in the pregnancy. So if she does have bacteria in her urine, it isn't recommended to start antibiotics. If she wasn't pregnant, then you don't check it routinely like at a well woman visit, only if there's signs and symptoms of an infection. Other things for the lab screenings part of a prenatal panel is a hepatitis B surface antigen. This is used to determine if someone has been exposed to hepatitis B in the recent past or a long time ago. And if there is some exposure, there's some further testing you can do to see if it's an active infection or it's a history of exposure. And then you're going to want to work with a physician to make sure you're minimizing the risk during pregnancy and delivery of exposing the baby to the infection and becoming a carrier. HIV, human immunodeficiency virus serology, is a recommended one to do. A lot of the midwives that I support will be community-based. It's not as much of a concern and risk factor, but it may be the profession. If they're nurses, medical assistants, it's a good idea just to get an HIV testing and just double check that it's normal, healthy. We're not at all implying that our ladies have something, but it's basic screening. You may or may not have symptoms for quite a while, and we want to reduce the risk to you and your baby. Some other things you can consider: a Pap screening is a well woman screening tool to help prevent and reduce the risk of cervical cancer. It's usually started at 21 years of age, and then you'll typically do it every couple years. The guidelines are changing regularly, and then after like a few that are negative, after 30, you can stretch it out with a negative HPV to every 5 years instead of every few years. It's not recommended to do a Pap smear under 21 years of age. They're finding so many changes with the cervix and abnormal findings that aren't really abnormals during teenage and post-pubertal years when there's a lot of changes. So don't even do this, but you can do a pelvic exam if they're before 21 and they've got discharge issues and concerns and sexually active and STD risk. You want to make sure you're assessing Other labs to consider if they're older, and you could just offer it to everybody. It is part of the standards of care, genetic testing. Some of this data is saying 35 advanced maternal age, some are saying 40 is advanced maternal age, but I would say most of the organizations are using 35 as that standard. And just put it in your notes. Even if you serve low-risk healthy ladies, you're serving the Amish and Mennonites and they have babies until their body can't have babies anymore, you just offered and you just put a simple note that they declined within your charting system. If they do want that testing, I've had a lot of people not concerned about the genetic risk factors, but they're really excited at 9, 10, 11 weeks to be able to know the genes, the chromosomes, if they're having a boy or girl before the 20-week ultrasound nowadays. So learn their family history. Do they have a history of cystic fibrosis? Do they have a history of neural tube defects within the family? You want to make sure that you're working with your local genetic counselor if there's certain things that are risk factors by history that could affect the pregnancy and what testing you offer. So there's some other things you can talk about based on the history. If they have Tay-Sachs syndrome, other family autoimmune conditions, TB skin testing for certain populations. If you're in immigrant populations, high traffic area, high exposure, international midwifery work, you just have to determine who you are taking care of. If you're taking care of a high African American population, you may do some hemoglobin electrophoresis just to see if there's any sickle cell traits and thalassemia and all these other hemoglobinopathies that you'll want to evaluate. So part of it is you get your lab work, you get your testing, you do a lot of questions. You ask questions on your paperwork, you ask questions during the visit. The first couple of visits, especially with their first baby, especially with the first baby doing a midwife in a private practice in a home and a birth center, they're going to have a lot of questions and want understandings of just what's normal and what's not normal and what does it look like for the care with a midwife? What if I have this come up? What are the setting, resources, and the style of midwifery that you offer within your practice? So you're going to ask them a lot of questions about their history, if they've had babies before, any complications with the delivery, if they've had a history of cardiovascular issues, diabetes, preterm labor, big baby, C-sections, growth issues. The list can go on and on. The nice thing, you can do a lot of that on your paperwork, and then you just review if there's anything concerning you want to touch base on. But your whole point is you want to catch risk factors, and you want to screen, and you want to watch closer, and you want to educate specifically on this person's individualized needs. So there's other things you want to go over. You want to assess their social history, their history of substance abuse, smoking, depression, immunization status. If they have a history of smoking, offering nicotine, offering support systems and counseling for addiction, if they're willing and motivated to change at this point. Our whole point is to support them in wherever they're at and give them guidance and education and allow them to make the best decision for them. Part of the other things you're going to do with prenatal care, every single visit you're going to touch base on key points. You're going to offer a Tdap vaccination in that third trimester to help boost passive immunity to the baby. And families can choose or not choose to have that, but you still are expected to offer the standards of care that are key risk factors across the board for the immune compromised population of pregnancy and the newborns that will be coming into this world that have never been exposed to a lot of these germs and bacteria and infections. You can consider in the flu season offering them the flu vaccine, the COVID vaccination, having a conversation. You can choose to have it within your practice. You can choose to outsource them to the health department and offer them support and getting that taken care of. You can refer them back to your PCP. There's a lot of different things you can do to help with getting the immunizations done if that's something they're interested in. You may do some extra ultrasound screenings, especially if there's something that's funny on the ultrasound. They noticed an anomaly, a growth issue. You have risk factors of the baby measuring too big or too small with your fundal heights. You're going to get further information. When you get closer to delivery time, you're going to talk about contraception options. You're going to see if they want a tubal, if they want natural family planning. They want to know all their different options and something you want to place an Explanon on, an IUD at 6 weeks postpartum. They'd like to do the diaphragm and have you help them fit with that 3 to 6 months after postpartum. You should be doing a depression screening throughout the pregnancy, and then the recommended guidelines are every touch base point that we have the first year postpartum with our clients, we should have a documented screening. We can make something very formal with them. There's a lot of different scoring systems out there, or you can just do a very high level touch base. How are you feeling? How are you doing? Are you having any sadness? Is there's so much postpartum depression and sadness happening, especially the last few years. So it's really important that we screen and not make any assumptions because of who we're serving, especially with domestic partner violence and family and abuse and physical, emotional. Any chance you get at the beginning of pregnancy to get them private. Sometimes I'll send the dad out to get some water, or I'll be like, oh, I'm just going to do a simple pap smear pelvic, and then I would have the mom alone where I can ask more of those private personal questions. And if there are any risk factors, you touch base and you discuss it throughout the pregnancy. You want to discuss the recommended weight gain during pregnancy, if they're underweight, their normal BMI, overweight, morbidly obese, what are the recommendations, how you can help support them with that, the different options to feed your baby once your baby gets here. You're definitely going to go over a lot of educational topics of what's healthy and how much calorie intake you should be having and what it feels like with nausea and vomiting and the hormonal changes happening and what's normal, what's around ligament pain versus these are signs and symptoms of an ectopic pregnancy. This is normal vaginal bleeding, spotting after sex, and cramping with constipation versus, this is not normal bleeding. You're now cramping and you're bleeding like a period and it's getting larger and larger with clots. They need to be able to know what to call you and what not is normal and just need some reassurance. Ultrasound considerations. It's routine standard to offer at 18 to 22 weeks an ultrasound screening to look at the anatomy of the baby. If you're a midwife serving in the community setting, you want to make sure that the baby is a good candidate, low risk with heart, lungs, kidneys. There's no severe anatomical issues that allow the baby to be delivered in the home or a birth center setting. Then a lot of times in the first trimester, it is standard care in the major medical system to do a first trimester ultrasound for reconfirming dating, but a lot of the clients in the home birth setting, they know their bodies really well, they have accurate last menstrual periods, they know how long their cycles were, they're very confident with their due dating. Sometimes they'll decline the dating ultrasound. So the standard of care is to offer both, and if you've got good dating from her period, but if she's been breastfeeding and she doesn't know when her last period is, this is the next best way. The farther along you are in the pregnancy, the less accurate the ultrasound is. So in the first trimester, give or take 3 to 5 days of accuracy. And if it's the second trimester, it's closer to a week, week and a half. Once you get in the third trimester, those ultrasounds are highly inaccurate, 2-3 weeks apart. We give so much medical world about the growth and the accuracy towards the end of, oh my gosh, we're going to have a big baby. The baby's being estimated at 4 grams and 10 pounds, and it's highly inaccurate, but we give it such credibility. So we have to think about why we're using ultrasound. When is it indicated? It's very appropriate if she doesn't know her period, she's breastfeeding. It's very appropriate to offer to everyone a 20-week anatomy scan, a touch base point to make sure that baby is normal and healthy. And then if she's not measuring too big or too small with her fundal heights, it's a good idea to get a growth scan and to follow up on things. So there's certain risk factors, there's certain indications to ultrasounds, but I think sometimes across the country it's overutilized. Carolyn Gager with Ultrasound for Midwives talks to me all the time, and I send people all the time. She is the expert and really goes into what does the data say, what is the evidence, because there's a lot of places across the country where they're like, we always do a growth ultrasound at 32 weeks, at 36 weeks, and the data doesn't support those just routine interventions besides doing it at 20 weeks gestation. So for prenatal care, it's typically recommended to start prenatal care at 8 to 12 weeks gestation. Obviously, if she has complications, she has concerns, she's not feeling well before 8 weeks, you can definitely get in a problem visit. You can see her an additional time. And then typically it's every 4 weeks that you would see them in that first and second trimester. The European model and people that have had babies before and are super healthy, you can stretch it out to more like 5 to 6 weeks gestation. That's completely appropriate. Once they start getting into the third trimester, then you're going to start doing it every 2 to 3 weeks. Typically, their high risk routine standards are every 2 weeks, and if they're normal, healthy, had babies before, well educated, they can do every 3 weeks. When you get to that last month of pregnancy, you typically will see them every week until their due date, and then it becomes every few days until they deliver. So these are some other things that it's kind of controversial. There's just as much data that supports doing routine urine analysis dipsticks at each prenatal visits, and there's some data saying that it isn't recommended and it's not something you should do. So I'd say 50-50 in practices I've worked at where they do it or they don't do it. Obviously, if she has a history of diabetes, she has a history of dehydration, she has a history of blood pressure issues, and you want to see if there's protein in your urine, you're ruling out preeclampsia. Some of these testing are very appropriate to do based on an individual basis, but you always have to be careful of what is routine, what does the evidence support to do something consistently to every single person versus if they have risk factors and individual needs. Especially during labor, intervention leads to intervention, and the same thing I truly believe goes to prenatal care. The more we do to them, the more we get interventions that we have to do versus we're doing the testing and the screenings based on her individualized needs. So measuring the tummy is a really important thing to do. You're going to use your hand the first 20 weeks of the pregnancy based on the top of the uterus being at the symphysis pubis, being 2 finger breaths underneath the belly button, the umbilicus, at the umbilicus. And then once you get to 20 weeks, you'll start measuring her tummy, and I tend to flip it over and not look at it, put my hand there, and then I flip over what I have because I try to keep my biases out as much as possible. Because if I say, oh, she's 24 weeks, we instantly put our hands to the 24 mark on the tape measure. So I always flip it over and I feel her tummy, and then I hold it over the pubic bone, and then I flip once my hand is holding in place to get the most accurate measurement I can possible. And then the last month you'll start doing Leopold's and actually feeling baby's position. You can do it for fun. It's great practice throughout the pregnancy, but I don't really care if the baby is breech at 26, 28, 32 weeks. It's that last month of pregnancy that I really care about baby position. So there's many different ways to just use this information to do a fundal height. It's a really important piece of information. You messing with the baby in the tummy and you get a kick and you get some movement, that's a very reassuring sign that the baby's oxygenated. So there's multiple things. It's not just checking the fundal height, but you're actually seeing how the baby responds and reacts to your cold hand, to your movement, to the stimulation. And if baby starts wiggling and responding, that's great signs of oxygenation, and that's where you talk to the moms about those fetal kick counts. And 26 to 28 weeks, wiggly babies are happy babies. So other things to consider when you're doing fundal heights: it's very difficult to get an accurate fundal height on someone that's a very morbidly obese woman. There's a lot of adipose tissue, there's a pannus, it distorts the information. You're going to get always, she's measuring 3-4 centimeters above. It's just not very accurate in the growth and the discrepancies of the baby. So a lot of women that are very morbidly obese will do serial growth ultrasounds just because our fundal heights aren't that accurate. So there's other things to think about with the anatomy. Scans are recommended between 17 to 22 weeks. If you do them earlier, you just have a higher chance with the heart valves and some of the anatomy not being able to visualize very well. So I tend to offer this at 20 to 22 weeks. Obviously, if there's something wrong, it's nice to know sooner than not to get further treatment and evaluation. But more than not, a lot of families get stuck with a financial bill because they didn't have a medical reason to repeat that ultrasound. And so you just want to be conscientious of the cost and the screening and try to be able to just get it at once. So it'll look at the anatomy. It'll look specifically at the heart, the lungs, the kidneys, the fingers, the toes, the spine. They'll look at everything in the baby, and then you'll get a nice ultrasound report after the radiologist reviews the findings that the ultrasound tech gets. We can, as midwives, particularly nurse midwives within our scope of practice, do point of care ultrasound testing. So if we want to get an ultrasound before 10 weeks because they're in our office and we couldn't find the heart tones, we can do a point of care and get the baby's heartbeat. If we want to confirm there's 1 baby, 2 babies, the baby's position, I can't really tell with my Leopold's. There's certain specific situations we can grab the ultrasound machine, but as far as the routine 20-week anatomy scans, that's not part of the scope of any midwife based on national organization standards. So there are lab testings that you can do. You can offer genetic testing, you can do screenings for chromosomes. Some are better to do from 8 to 10 weeks, some are better to do between 15 to 20 weeks. There's so many genetic testings out there. So I just stress to people, if they have risk factors or if they want a specific test, if they don't have any medical indications for it, they're probably going to pay out of pocket for that. But if they're advanced maternal age, family risk factors, but if they just want to know the baby's gender, curiosity, it's hard to put, besides just first baby, second baby, first trimester, second trimester as a diagnosis on the form when you're ordering it. So some of the other things you'll do is subsequent lab screenings between 24 to 28 weeks. You're going to offer a repeat CBC because the iron level tends to dip throughout the pregnancy. You're also going to do screenings for gestational diabetes. There's a lot of mixed guidelines out there. If they have risk factors, you're going to do a 1-hour GTT in the first trimester. It'll help you determine if they've got type 2 diabetes or if they've got gestational diabetes. A1Cs are really helpful to get at the beginning of pregnancy for people that are obese and risk factors. So you have a sense of what the average blood sugar has been the last 3 months. As far as routine screening during pregnancy, 24 to 28 weeks gestation, doing a 50-gram 1-hour glucose test or a follow-up with a 3-hour glucose test. Some places just do a 2-hour across the board. It depends on the population they're serving, the compliancy. You want to narrow down risk factors and then the screening and the official testing. I've done places where they just do the 3-hour, the 2-hour because the population. So when you're doing more community-based, some people would prefer to do the jelly beans or to do the 1 week of checking their own blood sugars at fasting and 1 hour after eating. There's just not any guidelines in the medical world of those standards being acceptable, but you want to have a conversation of the options with your patients, your clients you're serving, and ultimately they get to make the best decision of which screening tool makes the most sense to help make sure that they don't have risk factors for diabetes. If they're Rh negative, you're going to repeat the antibody screen and you're going to recommend to them the Rh immunization prophylactic, the RhoGAM, just because you don't know the baby inside if the baby's blood type is positive, negative. If she's negative and you've got a blood type of the dad and confirming and they can validate that this dad is also Rh negative, then the baby should be Rh negative, but there's just a lot of variables, and depending on the population you serve, you're going to individualize your service and screening based on their needs. You definitely want to repeat the depression and domestic violence screenings as much as you feel necessary, depending on the population you serve, their vulnerability, but at least do the domestic violence screening at least once in the pregnancy, at the beginning, preference, private, comfortable environment, build up a trust, make sure that they know the resources in their community if they ever need help. And then the depression screenings are definitely done, especially postpartum, more frequently because there's just so much mental health disparities that can happen after they deliver their baby. Definitely talking to them throughout the pregnancy if there's any changes, particularly if they're already a smoker and had a history of substance abuse, because hormones of pregnancy can make it really a deterrent for them, and then once the baby is delivered they may go back to smoking a bunch. If they've had a history of substance abuse and now they're tired and stressed out, they may be seeking ways to help cope with the stress in their life. So we want to be a resource that they can feel comfortable to talk to you. Breastfeeding is an important thing to start talking about when they're 28, 32, 36 weeks. They did some childbirth education. There's so much data out there that the more the provider makes breastfeeding normal and frequent education and reinforces it, the more likely they are going to stay breastfeeding and use you as a supportive advocate for breastfeeding questions. So when you get in the third trimester, 28 weeks until delivery time, there are some things you may want to consider based on the population you serve. If they have higher risk factors, they have a history of anemia, they have a higher exposure rate to sexually transmitted infections, you may be testing from 32 to 34 weeks on monthly, a repeat CBC, repeat STD screenings. They just got treated, their partner was supposed to get treated, you're going to do a test to cure a month later. You want to confirm that the treatment worked and that there's less risk for delivery time and bleeding and transmission of an STD to the baby. If they have a history of HSV and herpes, you're going to do prophylactic immune suppressants at the last month of pregnancy, get them started on some Veltrex daily. Even if they hadn't had an outbreak in years, you're going to visualize their perineum when it's delivery time, because if they have an active outbreak during labor, the recommendations are to do a C-section to help decrease the exposure risk to So there's other things to think about. You may consider doing at 32 to 34 weeks gestation an HIV test, a repeat gonorrhea chlamydia. There's many others, syphilis, RPRs, that kind of stuff you may consider doing depending on the population you serve. When you get to 35 to 37 weeks gestation, it's recommended to do a group beta strep culture. Around 20 to 25% of the population at some point has group beta strep normal down in their vaginal flora. It doesn't hurt them, it doesn't hurt their partner, but it can cause a rare but very serious lung infection in the baby. There's two types of GBS. There's the infection of early onset neonatal sepsis and then the late onset. And the current CDC recommendations, if they have a culture that's positive, is to offer antibiotics during labor to decrease the risk of transmission. A lot of our clients will go over the CDC guidelines and we'll show them the data, and I don't even think the average labor and delivery nurse in the hospital system realizes how low the stats are for getting it. It's like 0.7%, and then when you do the antibiotics it cuts it down to like 0.3%. So it never makes it 100%. It also isn't, people act like it's like your baby's going to get this, and if you do 2 doses of the antibiotics before the baby delivers, the baby won't get it, but that's not accurate. So your job is to give unbiased, informed consent, show them the data. Evidence-based birth has wonderful things about a lot of these screenings and standards being offered, and then let the client and the patient make the decision of what's best for them. And then during the 3rd trimester, you're just going to repeat the screenings, the testings, reinforce education, prepping for delivery. They're going to have a lot of discomforts and questions and concerns, getting ready for labor and birth. Your job is doing a lot of education in that last trimester and making sure that the mom is healthy and the baby's healthy so you can have a term happy, healthy delivery. So prenatal care is one of the most common preventative care services in the United States, and it improves the health of around 4 million pregnant women and their children every year. There's many screenings, testings, assessments, educational topics, touch base points that midwives and healthcare providers do during prenatal care. It makes a difference on when you start the prenatal care on what things you're going to focus on. If you start in the 1st trimester, you've got time on your side, you can do a lot of screenings, have a lot of education, build up that relationship. When you start getting into the 2nd and 3rd trimester, you're just missing a lot of screenings, you're missing a lot of educational opportunities, you're missing a lot of time to build up that relationship, and you just increase the risk. You just don't know what was happening. You don't know the exposures and the things that were earlier in the pregnancy because you weren't taking care of them. It's essential that every midwife looks at the standards of care. Are they being met? How can we excel? How can we serve the population we're taking care of best? What educational handouts can we do? What standards of care can we offer throughout our prenatal visits? And how can we make things where it's about education, advocacy, and reducing the risk for the mothers and the babies?